the OrthoPAC, hosted by Sam Dyer. Welcome to the OrthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Welcome back today, Chuck Dowell. Chuck is a PA who was on the podcast several weeks ago discussing some case studies. And Chuck, welcome back.
Yeah, thanks for having me back.
Yeah, we're glad to have you. First off, knee effusions. Chuck, can you please tell our listeners about the case study you have regarding knee effusions, x-rays, differential, and that sort of stuff?
Sure, yeah. So, like we talked about, I work in orthopedic urgent care. Swollen knee is one of those common things we all see in the office quite frequently. So just an example, I had a 48-year-old male present to the clinic, acute onset of swelling in the left knee, no trauma to the area, no accident, didn't have any fall to cause it, didn't do any repetitive activities or workouts that potentially could have caused it, denied any systemic symptoms, fevers, chills, sweats, didn't have any significant concerning medical histories. Anytime I see any type of swelling within the knee that's kind of spontaneous, I always ask about history of gout, pseudo-gout, diet changes, and he kind of declined all of that. So went to the examination. The examination showed palpable moderate effusion, maybe some slight warmth to the touch, no, not maybe a trace overlying erythema, but just kind of very soft pink in color. Did have some limited mobility, full extension, but flexion about 90 degrees caused that kind of a tightening sensation within the knee. Normal neurovascular exam, calf was soft and non-tender distally, so no concerns. DVT, in the area. Got some x-rays, because again, nobody can come in an orthopedic clinic without getting x-rays. Our standard is 4 views of the knee. X-rays didn't show any evidence of joint space narrowing, no arthritis. Patella was slightly elevated and lateral displaced, which is a common finding we see with these knee effusions, but otherwise normal appearing x-rays.
So he's got a BFK, a big fat knee. And
exactly.
We don't know why. We have a differential, Chuck. So what do you think this might be?
Yeah, so for me, anytime somebody comes into the office, I always think spontaneous effusion without a trauma is a big one. Medical history is important. So without a trauma, I think of, flare of some arthritis in the knee. Is the effusion prepatella or infrapatella? So is it a bursitis or is it a knee swelling? And then is it concern for crystal arthropathy or septic arthropathy or septic effusion with the knee? So all of those are kind of rolling through my head as I'm discussing the patient's history and kind of evaluating them.
So let's talk about the reason of trauma. I think it's obvious to a lot of folks, but I've told this to many people. If you ask yourself these 2 questions, how old is the patient and was there trauma or no, you can really narrow down your differential. And I was hoping you might elaborate on that a little bit for our new hires and our new grads. Why is it so important to know if there was a history of trauma?
Yeah, so I do the same. I think one of my biggest things is history, is knowing the mechanism of injury. And so I spend a lot of time on that and if there's a trauma or not. So if somebody comes in with a traumatic effusion in the knee joint and or a traumatic prepatellar bursitis in the knee joint, you're thinking more an internal injury, so possible ligamentous injury or meniscal injury, and possible fracture that can cause a trauma or effusion, or even a hemoarthrosis or blood collection in the knee joint. So I think it's important to elaborate if they had a fall, a twisting injury that caused it. Because again, if they come in without that, then those types of things aren't in my differential as far as a ligamentous injury, a meniscal injury, or a fracture to the area. And so then I can kind of start thinking about the other, differentials that we talked about. So there's 2 sets of subsets of differentials depending on if there's a trauma or injury associated with it or not.
Right. And you had mentioned the systemic disorders and, you had mentioned gout, that sort of thing. What sorts of things other than trauma can cause the knee effusion? You touched on a couple of these.
Yeah, so I think gout's a big one for sure. I think there's also different systemic disorders. Hemophilia can cause a knee effusion. Sometimes people that are on anticoagulants, I've seen this in people that take Coumadin, have a high INR level and they'll get a kind of spontaneous knee effusion, or sometimes just an innocuous small bump to the knee can cause the swelling within the knee. Diabetes can cause it. Rheumatoid arthritis can cause it. A lot of those immune suppressive disorders can cause it, and then hypercoagulable states can cause it for sure.
Yep, absolutely. And you had mentioned tapping the knee or an arthrocentesis. Can you explain to our listeners how you go about tapping a knee and whether you send the fluid every time or not, and there's also this little thing called a dry tap that I've unfortunately had happen before. If you wouldn't mind talking about that some too.
Yeah, so my standard procedure when I aspirate the knee or tap the knee is to have them in a supine position, so lying down flat. I do the lateral kind of subpatellar approach. Most of them don't like their knee fully straight, so I typically put a pillow under the knee, and that usually allows them to relax the quad enough where you can slide under that kneecap. I find a lot of the times if they're trying to hold it straight, their quad's contracted and they're pulling that kneecap down into the trochlea, and you're kind of losing your space there. So a little pillow under the knee is often helpful to kind of relax that quad. Again, I'll find that little sulcus right in between the superior margin of the patella laterally, just distal to where that quadriceps tendon attachment is at, and that very lateral trochlea set that's there. I'll mark that with my tip of my needle. I'll usually use about 5 cc's of lidocaine, 0.5%, 1%, whatever your preference is, to anesthetize the skin. Most of the time that does a good job as far as anesthetizing it. The capsule is usually where it's kind of hard to anesthetize, and that's usually where they feel a little bit of pain. So I'll kind of try to go deeper into the capsule. And sometimes I'll even use that smaller 27, 25 gauge needle to kind of get my target and go all the way into the joint just to see my trajectory of what I'm going to use for my larger bore needle when I do the aspiration.
So what about the fluid? Chuck, do you send it routinely or only if it looks cloudy? Or if you're confident it's osteoarthritis? I mean, how do you decide what goes to the lab and what doesn't? And then also let's touch on the dry tap.
Yeah, so I guess let's talk about the dry tap first because we're kind of already on the subject of the aspiration. So then I'll introduce that 18 gauge needle. A lot of the times it's loculated and a lot of the times it's in that suprapatellar pouch area. So I think that's for me why I like to go that lateral subpatellar versus having them over the side of the table and doing an anterior lateral, anterior medial. Because I think even flexing the knee over the side of the table pushes that effusion up superior patellar or suprapatellar, and a lot of the times you'll get that dry tap. So oftentimes because of that loculation, I'll try to kind of milk the effusion laterally, and or I'll have to reposition my needle to try to get that pocket where the fluid is at. I've found that if you kind of go bury the needle and pull it back towards you, oftentimes that pocket is in the superficial aspect. The needle kind of is just barely in the skin is the pocket that I typically find. If you do get a tri-tap and there's no effusion, it could be one of a couple of things. It could be that there's a hemarthrosis in there and it's just so coagulated and thick that it won't come out through an 18 gauge needle. It could be that you didn't get the loculation of where that was at, or it could just be that there's no fluid collection in there and the fluid is just in the subcutaneous tissue. Regarding analysis of the fluid, that's a difficult one. I think when I originally started, I would send every tap just because I wasn't confident in differentiating the color of the fluids on what it could be. I think if they have an underlying history of arthritis on the x-rays and the tap shows that kind of straw color fluid, then I'm not going to send that fluid because that's a pretty standard diagnosis of an inflammatory arthritic flare. You say, what is that straw color fluid? Well, I'm a beer drinker, so it's a terrible analogy, but I consider that to be like that Budweiser appearance. So you can kind of pour the Budweiser in. It has a yellow tint to it, but it's kind of a clear appearance. You can see all the way through it. That's that straw colored fluid that we often see. And most of the time, if the x-ray shows some arthritis, I won't send that. If I do the aspiration, I get more of that kind of thicker, turbulent fluid. I'll maybe consider sending that before I inject the cortisone. Oftentimes, that's the pseudo-gout or the gouty fluid. Again, that's kind of that weedy beer appearance, that hoppy beer appearance, which is just a little bit thicker, can see through but can't completely see through. If they have a history of gout or it's pretty straightforward on gout, I'll send the fluid, but I'll do the ejection as well because I'm not super concerned about an infection. And if it's anything concerning, I'll send it first before I do any injections. And if it comes back as a gout or pseudo-gout, I'll have them come back in and get the injection later, but potentially give them some oral anti-inflammatories in the meantime to suppress things.
And the labs that you routinely would get, let's see, we get a crystal analysis that'll look for our gout, pseudo-gout. We get cell count. And I think we don't really call it an infection until the white cells are, 100,000 or something. I mean, 10,000 white cells really mean nothing.
Standard literature is 50,000 and above, and then 70% neutrophils is standard literature for an infection,
Gotcha. But if you get 5,000 white cells, that's not an infection. Don't worry. And let's see, what else? Cultures and gram
culture and sensitivity. Yep, exactly.
Yep, those things. So, that's what we do with the lab. So, all right.
Yeah.
And okay, so you talked about this injecting the cortisone with knee effusions. Oh, if you're getting labs, if you're concerned that there is an infection, obviously you don't want to inject cortisone. If you're feeling that's really low and unlikely, I mean, inject cortisone. That's kind of what you said. Is that correct?
Correct. Yeah. So if their history kind of lines up, it's an arthritic knee on X-ray, and the fluid comes out and it's that straw colored kind of clear fluid, I'll inject the cortisone. If their history lines up, they're a male, maybe have a high Tyrian diet or had some hoppy beers or any of those kind of triggers for the gout or pseudo gout type concerns, or even have a history of gout in the past in their big toe but never had it in their knee, and it comes out that weedy beer appearance, I'll inject it typically, because I don't think that, as long as they don't have any systemic symptoms or concerns, or they don't have any medical conditions that would make them immune compromised, like diabetic or anything like that. I've grown confident in being able to look at the fluid and kind of go through the story and say, hey, this is something I would inject and not inject. But I definitely think if you're in your first few years and you're not confident with that, the answer is not to inject it, because the steroids will unfortunately make the infection worse. The infection will feed off the steroids as a source of food or fuel, and then you'll have this immune compromised state where your body can't fight off the infection because of the steroids. You definitely don't want to make that worse and kind of cause a worsening infection there. So I would say if there's any concern, definitely send it first, treat them orally, and then inject it later if it comes back negative.
Perfect and well said. And you know what, listeners? Where can you get a comparison of hazy IPAs and knee effusions other than Orthopedics? You got to love ortho. So anyways, Chuck, thank you so much for being on today, and look forward to our next talk.
Of course.
Thank you for joining the OrthoPAC podcast. Please follow the Physician Assistants in Orthopedic Surgery on social media. Connect with us on Facebook, Instagram, LinkedIn, and Twitter. Please subscribe to our podcast. If this has been helpful, please take a moment to leave a review.